Okay, welcome to the deep dive. This session, well, it's really specifically tailored for you.
That's right. You're a final year med student. You're right there on the edge of starting your clinical career.
Exactly. You've spent years building up knowledge, you've got that EBM foundation down, you know the theory, the acronyms.
ITO, yeah, all that stuff.
But how do you actually, use it at 3 a.m., middle of a busy clinic when you've got, minutes?
Yeah, not hours for a literature search. That's the key difference, isn't it?
It really is. And this deep dive, well, it's built right from your source material. Think of it like the ultimate set of notes.
Yeah, notes designed specifically for students like you, trying to bridge that gap, classroom to clinic.
Our mission today, let's unpack these notes together. Pull out the really crucial stuff. Make that jump feel a bit less intimidating.
Give you a real sense of how to apply EBM, like from day one. Take what you know and make it work practically.
Because at its core, and your notes hit this right away, EBM isn't just reading papers, is it?
No, not at all. It's about thoughtfully pulling together the best evidence we have.
Right.
With your own clinical skills, your judgment.
Which you're developing right now.
Exactly. And crucially, what the individual patient actually values and prefers.
It's the antidote to just, well, this is how we've always done it.
Precisely. So let's dive into what your notes highlight first.
Yeah.
That foundation.
All right, so section 1 in these notes, it's really about consolidating. EBM is more than just a concept. We've all seen Sackett's definition.
Oh yeah, the classic. The conscientious, explicit, and judicious use of current best evidence.
In making decisions about the care of individual patients, and your notes really unpack those key words.
We do. Like conscientious, that's about being diligent, mindful. You're actively looking for the best info.
Explicit, being clear about your process. With yourself, your team, the patient.
And judicious, that's vital. Using wise judgment. EBM guides, it doesn't dictate like a recipe book.
Current best evidence medicine moves fast. Got to keep up. And individual patients. That's the anchor, right?
Yeah. Absolutely. It's not about population stats primarily. It's about the person right in front of you.
And you can't have EBM without those 3 pillars your notes stress so much.
Right, the 3 legs of the stool. Research evidence, your clinical expertise, and the patient's values or preferences.
Your notes make a great point. Try standing on just one.
Exactly, just evidence. You're creating guidelines, not people, just expertise. You risk, outdated habits or biases creeping in.
And neither works without knowing what matters to the patient. What are their hopes, their fears?
The real power, like your notes show, is weaving them all together. Integration.
It's interesting, too, how the notes touch on the history. This wasn't just dreamed up recently.
No, definitely not. The term EBM came from McMaster in the 90s, sure, but the idea goes way back.
Like Pierre Louis in the 1830s using numbers to question bloodletting.
Or John Snow mapping cholera in London. Systematic observation informing what you do.
So the modern EBM push, your notes say, was a response to
Wow.
information chaos.
Pretty much. Information overload, huge variations in practice for no good reason, needing to move past just expert opinion.
And inevitably, when something big like EBM comes along, you get misconceptions.
Oh, definitely. Your notes warn you about the common ones.
Like cookbook medicine.
Yeah, that's the big one. Your notes push back hard judgment and tailoring are key. It's not just following a recipe.
And it doesn't only value RCTs, right?
Absolutely not. Different questions need different evidence. We'll get into that. And it needs clinical expertise to make sense of it all.
People say it's too time-consuming.
Well, it can be, but your notes give strategies for efficiency. And it's not just for treatment. It's diagnosis, prognosis, harm, everything.
A universal toolkit, basically.
That's a good way to put it.
Okay, foundation solid. Let's move to the workflow. Step 1, asking the right question. You've done PIO in class.
Yeah, formulating them.
But your notes shift focus to why this is like a clinical superpower in practice.
It really is.
Yeah.
The notes list the benefits. A good question clarifies your own thinking right off the bat.
Makes searching so much more efficient. You actually know what terms to punch in.
Exactly. And it tells you what kind of evidence you even need. Is it therapy? Diagnosis?
Helps you talk to colleagues clearly, too.
And fundamentally, it frames how you evaluate whatever you find. You know what you were looking for.
And PR, population, intervention, comparison, outcome, that's the classic structure.
It's the workhorse, yeah, especially for therapy questions.
Yeah.
But your notes mention variations, too.
Like PIR, adding time.
Right. Crucial if timing matters.
Yeah.
Or PIRD for diagnosis population, index test, reference standard, diagnosis.
The principle is the same, though.
Sure.
Define what you need to know precisely.
And as the notes point out, recognizing the type of question therapy, diagnosis, prognosis, harm, maybe even understanding patient experience.
Which might need qualitative stuff.
Right. That tells you where to even start looking in the evidence landscape.
Which brings us perfectly to navigating that landscape. The hierarchy of evidence.
The pyramid. Everyone's seen it.
Mm-hmm.
Expert opinion down low, systematic reviews, and meta-analyses often at the top.
Showing that general increase in controlling for bias as you go up. RCTs are strong for treatment effects because of randomization.
And your notes are really emphatic here. The pyramid is not rigid. It's not dogma.
That's such a crucial point.
It really is. Your notes stress that the quality of a specific study and whether it actually answers your clinical question matters way more than just its design type.
So a really well-done observational study might be better for, say, rare harms than a sloppy RCT.
Exactly. Your notes probably talk about question-specific hierarchies and definitely about assessing the quality within any study design. It's less about the label, more about how well it was executed for your purpose.
Okay, let's quickly run through the main study types your notes covered, their uses, the big limitations you need to watch out for.
Sure. Starting low down. Case reports, case series, good for spotting new things, generating ideas, but zero causality. Can't prove anything.
Cross-sectional studies.
Snapshot in time. Good for prevalence, seeing associations. Quick.
Yeah.
But you don't know what came first, the exposure or the outcome. No temporality.
Case control studies.
Good for rare diseases. Looking back for potential causes. Efficient. But, very prone to bias.
Like selection bias. Who gets in the study?
Yep. And recall bias, people with the disease might remember things differently than healthy controls.
Yeah.
Big problem.
Okay, moving up the ladder.
Cohort studies. Now you're following people forward in time. So you can establish temporality. Exposure comes before outcome. Good for incidence, risk, multiple outcomes.
Downsides.
Can take ages, cost a lot. People drop out lost to follow up. And confounding is a big one. Other factors muddying the water.
Right. And then the standard for treatment effectiveness.
RCTs. Randomized controlled trials. The gold standard for cause and effect with interventions. Randomization is key, minimizes bias, creates similar groups.
And not perfect.
No. Can be expensive, take a long time, and sometimes the people in the trial are, well, cleaner than your average patient with multiple issues. So generalizability can be a question.
Got it. And finally, the top of the typical pyramid.
Systematic reviews and meta-analyses. They pull together multiple studies on the same question. A good systematic review uses rigorous methods to find, appraise, and synthesize studies.
Increases precision, reduces random error.
Ideally, yes. And meta-analysis pools the data statistically, if it makes sense to do so. But they're only as good as the studies they include.
Garbage in, garbage out.
Pretty much. Your notes would definitely mention watching out for publication bias. Maybe only positive studies got published, and heterogeneity, meaning the studies are too different to combine meaningfully.
So the takeaway your notes stress is matching the design to the question. RCT for treatment, cohort for prognosis or harm.
Case control for rare harms. Diagnostic test studies for diagnosis, yeah. Makes sense.
And practically when you're slammed in clinic, your notes say, start with filtered evidence.
Absolutely. If it exists for your question, that's stuff like systematic reviews, good clinical practice guidelines, evidence summaries. It's already been appraised to some extent.
Saves time compared to digging through individual unfiltered primary studies.
Huge time saver. Start filtered whenever you can.
Okay, efficiency is crucial. But whether it's filtered or unfiltered, you still need to quickly assess it, right? How do your notes guide that practical appraisal, say for an RCT you find?
Yeah, they give you the quick hits, the stuff you need to check fast. Likely based on things like CASP principles, but streamlined. For an RCT, was randomization actually done well? Were the groups similar to start with?
Did they lose a lot of patients, and how did they handle that in the analysis? Intention to treat?
Right. Was there blinding patients, docs, assessors? Were the groups treated the same except for the intervention? These tell you if the results are likely trustworthy, the internal validity.
And then interpreting the results clinically, your notes have specific advice there.
This is super important. Your notes push you way beyond just looking at the p-value. Look at the size of the effect, the magnitude.
Absolute versus relative risk.
Yes, both. Your notes probably stress this. A 50% relative risk reduction sounds amazing.
But if the baseline risk is tiny,
the absolute risk reduction might be minuscule, like 1 in 1,000. That's why your notes likely hammer on the number needed to treat the NNT.
how many people you need to treat to prevent one bad outcome?
Exactly. It's intuitive. If the NNT is 1,000, is the drug worth it? Compare that to an NNT of 5. Big difference in clinical impact. And check the precision, the confidence interval.
Does it cross 1 for ratios or 0 for differences, meaning no effect is possible?
Right. Or is it super wide, meaning the estimate isn't very precise? Got to look at that.
And then the applicability question to your patient.
Always. Your notes will have questions like, is my patient similar enough to the study, folks? Did they measure outcomes that actually matter to patients, not just lab numbers?
And for this patient, with their values, are the benefits worth the harms and costs?
Exactly. Your notes warn against common errors, like confusing stats significance with clinical importance or overinterpreting subgroup analyses.
What about observational studies? Your notes say they're essential sometimes. How do you appraise their trustworthiness quickly?
Yeah, vital when RCTs aren't doable, like studying smoking harms. Your notes flag the big threats. Number 1, confounding.
Is something else explaining the link?
That's the question. Look at how they tried to control for its statistics, matching but always worry about residual confounding, stuff they didn't measure or control for.
What else?
Selection bias. Who got into the study? Are they different in important ways? And information bias. Are exposures or outcomes measured badly or differently between groups?
Like recall bias in case control.
Classic example. People with a disease might recall past exposures differently.
And the huge difference from RCTs.
Causation. You just can't infer it with the same confidence. Your notes will say, observational studies show association.
To even think about causality.
You look for other clues. Exposure came first, temporality, dose response, biological plausibility, consistency with other studies, and again, look at absolute risk difference for clinical impact, not just relative risk or odds ratio.
And don't assume a negative observational study means no effect, right? Could just be too small.
Exactly. Power matters.
Okay, and for systematic reviews, the recommended starting point. How do you check their quality fast?
Your notes give you a quick checklist, probably based on tools like Amstar. Did they search thoroughly? Clear inclusion criteria.
Did 2 people independently select studies and extract data? Reduces bias.
Crucially, did they assess the risk of bias of the studies they included? Using a good tool. How did they handle differences between studies, heterogeneity? Did they look for publication bias?
So you're appraising the review process itself.
Precisely. And again, did they report absolute effects? Is it relevant to your patient?
All right, this is the crunch time. Theory meets reality. How do your notes guide you in actually bringing this EBM stuff to the bedside, especially when you're just starting?
They frame it as a cycle, something you practice daily. Step 1, tune your uncertainty radar. Notice when you don't know the best path for this patient. Don't just guess.
Step 2, formulate that focused question. PFIO, PIRD.
Step 3, find pre-appraised evidence efficiently. Your notes probably bang the drum for point-of-care tools.
Yeah.
Smart searching. Time is short.
Step 4, quick critical appraisal. Validity, importance, applicability, the VIA approach, maybe. Assessing what you found for this patient.
And then, step 5, the crucial one.
Integration.
Yes. Your notes call this the art, combining the evidence with your clinical expertise, your judgment, your experience, your understanding of the patient's situation.
And always the patient's values and preferences.
It's not rigid rules. It's shared decision-making, a conversation informed by the evidence, tailored with the patient. And step 6, evaluate. Did it work?
Right.
Learn from it.
You must have some practical tips for junior doctors juggling all this.
Oh yeah, realistic ones. Efficient searching.
Yeah.
Know your go-to resources, bookmark point-of-care tools, teamwork, lean on colleagues, journal clubs, librarians.
Patient engagement. Decision aids. Teach back to check understanding. Really practice eliciting values.
And continuous learning. Every patient is a chance to refine your EBM skills.
But starting out, you're going to hit roadblocks. Your notes prepare you for challenges.
For sure. The reality check. There's still that evidence practice, gap change is slow, systems resist, people have biases.
And the evidence itself isn't perfect. Gaps for certain groups, publication bias, industry influence maybe.
Trials often don't reflect the complex patients you actually see.
Speaking of complexity.
That's huge. Applying trial data for one condition to your patient with 5 chronic diseases, multiple meds, complex life, that takes real judgment. How does this evidence fit this person?
Plus, resource limits, time, access, cost, all real-world pressures.
Yep. All impact how you can practice EBM day to day.
Your notes also mention EBM adapting to different settings.
Yeah, it's not one size fits all. Primary care needs broad knowledge for undifferentiated problems. Focus on prevention. Acute care needs rapid decisions. maybe more protocol-driven.
Chronic disease, long-term goals, patient self-management, resource-limited settings,
Right.
focusing on what's feasible, cost-effective, locally relevant.
Exactly. Different pressures, different questions, same core principles.
Looking ahead, what's the future of EBM, according to your notes? What should students be aware of?
Some really exciting stuff. Precision medicine tailoring treatment based on individual biology, maybe more end-of-one thinking.
Real-world evidence using data from EHRs, routine practice, pragmatic trials to see what works in the real world, complementing traditional RCTs.
AI and machine learning potential tools to synthesize vast amounts of data, maybe offer recommendations, but you'll still need sharp EBM skills to evaluate both.
And more focus on the patient.
Definitely. Patient-centered EBM, more patient-reported outcomes in research, better ways to do shared decision-making genuinely.
These trends are really going to shape the careers of students listening now.
Absolutely. Huge potential for better care, but also new challenges handling complex data, keeping the human touch central.
So as you prepare to step into your careers, remember this deep dive, this look at your notes, it's just the start. EBM isn't static.
It's dynamic, it's lifelong. The power, as we've seen, comes from that thoughtful integration, best evidence, your expertise, and the patient's values for each person.
You're not just going to use EBM, you're going to help shape how it evolves.
That's right, you're the future practitioners.
So here's a final thought to take with you. In this world of exploding information, amazing technology, but still finite time, how will you strike that crucial balance? How will you use the best data while always connecting deeply with the unique human being you're caring for?
That's the challenge and the art, isn't it? Being a great clinician in the EBM era, good luck out there.
Yeah.
And congratulations on getting this far.